We're going to spend a little time talking about meaningful use as it applies to implementations. So, as we begin the journey, it's an analogy that we can make in terms of implementations in our world. And so, we begin looking at the beginning of the universe and the Big Bang Theory, and how that this was the prevailing cosmological model, that this was a well-tested scientific theory, widely understood. So as we continue this analogy, we look at how the Big Bang Theory came to be and how we apply that to the implementations of electronic records. And so there was initially the expansion, which was the actual implementation itself, the early hot state, which was the irate physicians that came to be. There was a formation of what was considered helium gas, which is from those irate physicians. And then the formation of galaxies, ultimately the hospital units that were part of this. So ultimately, when we look at that galaxy, we have different parts of it that were the stars, which are considered the early adopters and champions, the stellar remnants, which is the majority, the interstellar medium of gas, which is the leftover from the irate physicians, there's the dust, which is the late adopters, and of course that important part that we don't understand well is the dark matter, which are the resistant or defiant physicians as we go along. So, being from the great state of Ohio, the Big Bang was a novel approach to implementation of clinical records, such that we're going to move move caregivers from paper to an electronic world. So let's first talk a little bit about the alternatives, because these are important. There are pieces and parts which are parts of the either CPOE, documentation, or otherwise. They're parts that involve nursing or physicians. There's mini bangs, which are small areas such as hospital units or floors of a hospital, or individual physician groups. So there's different models require different efforts, and most importantly, there could be reasons why we have these different pieces and parts. So there's parts of the Big Bang versus the alternatives that. Some of the euphemisms that are out there is the rip off the Band-Aid approach, which is really the Big Bang, or the death by 1,000 paper cuts, which is usually what folks are talking about. So we want to try to minimize the paper straddle that comes along, if possible. There's usually less risks of delays, and then the pain about these types of implementations is directly related to the amount of change that you need to inflict on the clinicians. So when you look at the alternatives, there's usually it's a little bit less strain on physicians sometimes, because frequently when you go back and re-implement another part of the record, it requires additional training, additional time physicians have to put into learning, and it becomes very difficult. But it's definitely an opportunity to stabilize the efforts, stabilize the system between efforts, but it does make going forward pretty difficult, especially if there's long delays in the implemental alternatives. So this was a little interesting. I thought this slide was appropriate for New Orleans in terms of change. I couldn't help but add that to the presentation. So I couldn't know which one to really go into. So when it comes down to it, this is really why I took my job, and it's really important that folks do remove their shoes and bow when they enter. But ultimately, the big thing that we really need to talk about a little bit about is change management. We're going to have a little session on change management here in this booth later today, but initially, it's really important to recognize that these efforts are really, really important, that it's usually difficult. The greater the gap between the present and future state is the more difficult the change process can be to adopt. And so when you go from, if you have an alternative effort in a piece or a part, the change effort isn't usually as much, but if you're doing a big bang, there's a huge change effort for clinicians that you have to pay attention to, and really need to focus on these up front and deal with physicians. So we'll talk a little bit about that as we go along. But the proof comes in a slide that's produced by our friends at Deloitte, where the people, process, and technology account for a huge portion of that, of which the people processes account for well over 60% of the efforts needed. And when it comes down to it, that when you approach any change effort, this slide has shown that there's an inertia that any group has to managing a change, and there's usually some success that goes along with that. But there comes a point in time during the process that without these key things along the right margin of the slide, your whole effort can be very marginalized. So understanding leadership, engaging the resistance to change, understanding the gap that exists in a dip in productivity is extremely important. And overall, you need to try to get folks to and leverage these buy-in strategies as you go along. So when you look at the physician piece to this, is that you need to recognize that physicians, like a lot of other folks during a change process, are going to fit into this neat little Venn diagram. There's folks that are going to be leaders, and they're going to be easy ones. In fact, sometimes you have to hold them back. And then there's the early adopters and the groups that are represented there alongside them. And then there's the broad group of the medical staff, and then there's the group that we need to understand are the late adopters. Now, the important piece to this is that you can pretty much gauge who's going to either jump into either the early leader group or the late adopter group. It's the broad group of medical staff and which direction they may go, and can you lead some of those into one, certainly up into the leaders or certainly the early adopters. So that it's understanding the medical staff that you're dealing with that's the most important piece. And the other part of it is having a strategy for some of the late adopters. Now, the nice thing is that what you don't want to do with your medical staff is stop here. You want to be able to look at those physicians that are the busy physicians that are driving your procedural areas, the surgical areas, and you have to try to understand what group, what segment that those folks fit into. So understanding how many orders they do, how much documentation they do, have to segment and try to categorize those physicians into those groups too, to try to help you understand where your support's going to go down the road. So busy slide, and I'm going to go through each of these sections one by one, but this is sort of a summary slide of the physician adoption pieces and actually certainly the parts that'll make that up. So as we talk about governance, and just some brief things about this, is that when you first get folks together, the whole the oil and water theory here with this particular cartoon is really true, and it still continues to happen today, even in some of the more advanced organizations, that there's still new physicians come in and they may have absolutely no idea what this is all about, and so you have to treat them much the same as the folks that you've dealt with in the past. So with governance, importantly, you want to maintain a clear vision. You have to basically set realistic expectations. You have to remedy for loss of control. Remember, physicians are a bunch of little CEOs running around in their own domain. And so the recognition of that, and then to be able to counter that with support, a little love and TLC, so to speak, and understanding what their roles are and how you can engage them in the process is important. And importantly, you want to make sure and let them know where their decisions can be helped, or where their decisions can be made and how they can help the organization. And ultimately, you want to begin to form an advisory group of some form, call them committees, groups, whatever you like, but maintaining and having your leaders have a group is really, really important. So communication, can't underestimate communication, lots of pieces to that. So some of it's just simply creating awareness and tell them the truth. Don't sugarcoat anything of what you're doing, so they clearly understand. Want to build knowledge and manage their expectations, so you want to have forums and parts of demonstrations of the system that they can see, so they can get sort of a feel for it. Fear of the unknown is a huge thing for physicians and clinicians as you go through this. So you want to then step up and identify the super users. Those folks are their potential early adopters, and you want to make sure that they're engaged. You want to educate them so that they clearly can understand and help going down the road. And then ultimately you want to enable and motivate all the users, be able to give them a sandbox if they like, have cyber cafes or small segments of the system you can show them from time to time, jump into their medical staff meetings as much as possible. And then ultimately on the back end, you want to let them know that you're going to help them build proficiency once they get there. So let's talk a little bit about training. Certainly one of my areas, and there's no lack for needing narcotics during training. You just want to make sure that you have plenty on hand so that that there's clinicians also understand that that's available. So here the computer training has started within in the hospital. So purpose of training is just, it's pretty basic. Is to introduce the physicians to the training or to the system environment. And what you want to do is you want to get them enough basic knowledge and information so they're proficient, or they're not proficient, they're able to at least handle day one of their life. Because there's going to be a lot of stuff, it's estimated about 20% of what they get in training they retain. So it's really difficult. So you want to make sure that you understand that and manage that as you go along. So the whole philosophy is that, and our approach is that it's required. Get that through the medical executive ranks, whatever it takes to make training required part of the training experience, or that is required. And then we take training and we make it relevant to the role, so that, you know, if you're a surgeon, you have one basic set of types of training, and that they are exposed to what a surgeon would have. So whether it be scenarios that are related to surgeons, scenarios related to internists or hospitalists, and so we try to make our training experience so that they understand that. And so we also try to group our clinicians in the class together. It doesn't always happen that way, and for various reasons of scheduling and things like that, it doesn't work, but at least we make the attempt to make that happen. And the other thing about our training is that in this particular case, where we had a hospital that was really on the cusp of wanting to do meaningful use, is that what we did was we baked in a lot of the meaningful use parts and rules and things like that, so they understood what was going to be important to help them gain and be successful at attesting for meaningful use. So the e-learning, it's one important piece. A lot of folks will either jump, both feet into this. Some will do parts of it, but basically a couple schools of thought. Either you do all e-learning or you do some e-learning. And if you're going to do all e-learning, you need to make it interactive so that there's the clinicians aren't just zoned out by looking at something or watching things. So there's got to be some significance to that. So the time that they spend needs to be pretty minimal. 4 hours max is for an e-learning class. We can do the whole class in 4 hours. So e-learning needs to be done in that time or less. As well, the important part is that make sure that they have breaks in the e-learning process, because it can be pretty boring and monotonous otherwise. And again, the whole thing about proficiency and interactiveness to the courses really needs to be there. And the other part that we use regularly is small videos for some of the short segment learning that, after the fact, that something that a handout or otherwise might fall short of, we frequently will do video instruction. So with our instructor-led classes, it's where we partner with our LEGO friends here, is that these are developed again for specific end users, and that there's some specialty consideration and segmentation that we've talked about, which is really important. And that with your providers, you have to recognize that many of them might have more than one course to take. So, for example, our obstetricians, we've actually combined and set up a course for them because they have a separate module built within the system. But they need to take not only the course for obstetrics, but also surgery and also the normal clinical documentation. So we've tried to bake those into the courses, but try to minimize the number of classes they have to take, but some folks will have to take more than one. So when we talk about activation support, where we actually get more, a little deeper, and this is one of my favorite slides, those of you golfers, but we've had clinicians yell out to us like this, you can imagine. So activation support. So basically this is the opportunity to further their knowledge, and we'll talk a little bit about what's called personalization, which I think is absolutely the key to their training experience. And then there's the immediate post-activation one-on-one with physicians. So we have 3 different methodologies. One is to continue the personalization, and again, I don't want to talk too much about that. I'll tell you about that in the next slide. There's the types of support are either the buddy physician, which we can align one-on-one physician to a support person to help. We can also do a zone defense where we actually station folks on units or floors, and we usually have a combination of both those things going. And then you also have to plan for this stuff called Groundhog Day support, which is typically for hospitalists, emergency room physicians who may work on day 1 or shift 1 and then not work again for a week. And they may lose a little bit, may lose a lot of what they've originally learned. So it's important to have a plan for that. And then the important thing is that you need to somehow plan for a long-term support. Usually the acute support, if you will, ends in a couple of weeks. But you need to have an extended support plan that probably goes out a good 3 months. I've recommended that. Some folks in larger facilities may go out 6, but even beyond that, you need to have ongoing chronic physician help at the elbow for new physicians, ones that come onto your medical staff. And so there needs to be residents if you have them. So it needs to be an important thing, as well as a opportunity to have an annual review and proficiency evaluation. And we're not always real good at that and building that in, but that usually comes in due time. So personalization is this one-on-one with a super user. So someone, ideally a physician, is done prior to go live. So you go through the setup, so you go through order sets and documentation templates and any other parts to the system that you need to go through, set them up in their production environment, and it really helps them on day 1. Physicians have so told us time and time again that personalization was the thing, the key to make their day better on day 1, day 2, day 3. And what ends up happening is by the time they get to the end of the first week, they're actually pretty proficient and they're pretty good at the system, to the point where they're asking more sophisticated questions and wanting to have a significant increase in their knowledge and time while they're there. So this was the personalization form that we used at the hospital that we'll talk a little bit about here. It goes through creating their patient lists, creating their initial setups, their documentation templates, their order sets, preference lists, whatever it took. And this was the key form for them. And what we typically do is we ask they sit a couple hours with us one-on-one. Frequently physicians have come back time and time again. We had a couple of physicians come back 5-6 times to do this. So the other piece to this is that is this a benefit or not? And so what we've done is we've actually taken our local Cleveland Clinic hospitals that we were implementing the CPOE module and documentation with them. And actually the interesting thing is that as we came in and began introducing personalization, we did a little bit on the east side, and then as we went to the west, it was well formatted and well done. And you can see the adoption rates measured by CPOE rates certainly went up substantially from where we were on the east side to the west side hospital. So it was a fairly significant, and we think it's more than just anecdotal evidence, but it was a substantial proof that we felt personalization was the way to go. And so we've actually formalized that in all our implementation processes. So as far as long-term support goes, here's the goals that you want to try to set for to improve efficiency and speed, to reduce the potential safety events, so they're getting a little bit more sophisticated in the needs out there. What you don't want to do is let doctors get stagnated in the way they learn. Frequently what ends up happening is physicians will come in and they'll learn it one way, they'll learn it potentially an easy way, but it may not be the best way. And so it's important that they learn these new things. we've actually created a course for our physicians to go through. It's called Rediscovering Epic Care, which they need to be in the system for 3 months before they even go through this course. So it's our way of spending a whole entire day with them, trying to get them to understand and improve how the system works. So here's our case study. This was Ashtabula County Medical Center. It's a little facility 60 miles northeast of Cleveland, and it's a freestanding, not-for-profit affiliate of the Cleveland Clinic. Had a small percentage of actual Cleveland Clinic physicians, and they decided to do the big bang. And what they did do right out of the gate is they budgeted for meaningful use at the end of that particular fiscal year. So this is what we were doing, and we ended up dropping in documentation, nursing, pharmacy, those things that are listed there. And the result was a Paperlite process. We still had a few things that were on paper, typically things that patients dealt with. So here were the successes. We had committed leadership from the executive rank. We had developed and found physician champions that they put forth from their medical executive ranks that this was a required part of their work effort, and that they wanted to leverage a lot of the existing content resources from the Cleveland Clinic system, which is what we brought. These are some of the slides that we actually used for them. You can see that, we basically came in and said, here's what we're going to do. Some of the point of care decision support that we were bringing with the system, so they could actually get a look and feel. So these are some of the early slides. We basically said, look, this is going to be hard. It's not going to save you time, and that the important thing is that we wanted them to understand that they had to put in a little work and time and effort also. And this is what when we were working with our physician champions, what we wanted to do is make sure that they understood what their roles were going to be. So ultimately, these were the communications we used. A lot of medical staff meetings. We went to a lot of these, the posters, cyber cafes, and various other modes of communication that were there. This was a poster we used. So we also let our patients and the staff everywhere, so basically patients and their families, know that the hospital is going to go through a transition. A lot of organizations will either say yay or nay to this. And then our folks at Allego, they were very instrumental, very helpful. There's a huge set of skilled workers that they have. We brought them in for work with the physicians and the nursing staff, as well as the ancillary staff. They were very, very helpful to us. They came in initially, and then the timelines were that they were there on site a good couple months before, doing a lot of the training, and that they were on site for a good 4 weeks for support. And that the nice thing is that the site can determine whether they choose additional support or not, and go from there and actually contract individually once our implementation team has left. So their numbers, they supplied us with 8 trainers. We had 4 folks that worked with personalization with us all the time. These folks we helped train, and they worked with us directly, worked with the physician staff. And that the nice thing is that this was a great team approach, both with the champions. They had Allego had site executives on staff and on site that were able to review and see how things were going. And then the great added benefits were that they were very flexible with their staffing. We needed certain types of support in certain locations, and they were very good about moving folks around, getting additional folks if we needed it. And then again, they were able to have separate contracts with folks with the hospital for an extended support model. So here was our personalization lab. This is what it looks like. And where we have a bank of computers, we have our support staff sitting in there, and they have physicians come in. They come in on appointment, or they can walk in, doesn't matter. And ultimately, they can be personalized. So the nice thing is that we had about 90% of the physicians come in. And a lot of the physicians don't come in for various reasons. Either it didn't fit their schedule or whatever. But the administration and the executives of the hospital were very good about reaching out to those physicians who they hadn't seen, who were busy physicians, to make sure that we had those folks in. So here's the result. you can see right out of the gate, this is the first week of CPOE rates, and then on into the first several weeks a month. You can see that right out of the gate, they were hitting 80% of orders that were done by physicians, had a relatively low verbal order rate, and ultimately a large number of their orders were being placed by order set, so order set utilization was pretty significant. And then you can see this is a slide that is basically the same type of slide, but it goes out through the end of this, end of the last calendar year to show you that there was a sustaining of that order entry rate at this hospital. So it was a very successful implementation across the board to continue to attain those types of order rates. So it doesn't end there. So the other piece to this was an actual hard dollar ROI, that while it's a small hospital, but they were going to see an annualized savings of about $75,000 just in transcription costs. That was just the hard transcription costs. It didn't have anything else to do with paper or anything else that may be a part of that. So that was actually a very, very beneficial thing for that hospital. So what about meaningful use? So here's the other rub. That of course the big thing is that we were going live on June 23rd, and they want to submit the fourth quarter for meaningful use. So they wanted to submit July to end of September for meaningful use. Pretty tough. So we knew this, we knew that up front, and so we tried to drive that through all the communication processes that they had. As well, we set them up with our reporting, data reporting system, and also that we brought, of course, the lessons that we'd learned with all the hospitals and some of the tough areas that they had. So the most important part is that we actually have true meaningful use, and that this is the meaningful use of grapes as we all know it. So ultimately what we wanted to do is walk in there. We had to understand all their thresholds, their patient volumes, what their CPOE rates were going to look like, what the problemless use was going to be. That was usually the biggest rub in most of the hospitals, was problemless use. And things like we had to keep track of things like smoking cessation, use of advanced directives. And so they worked with the physicians on and on, and we had to dog them if we had to. And the most important thing was to be able to give them the data so that they could actually empower themselves, so that they could reach out to their physicians for those who weren't working well. So actually the talk is 100 days. They actually made meaningful use in 96 days. So the important piece of this is that, as you know, it takes a little while to achieve a 30% CPOE rate, even because you're starting at zero. And so same thing with problemless use at 80%. There needed to be a substantial period of time to where their average hit 80% for that measurement period. So the important thing was that it just took them some time. So this is our reporting sheet for meaningful use. We generate our own data. It's basically a combination of Crystal reports that generates this data out of our Clarity reporting system for Epic. And this is what their report looked like. So they were all green, and they hit meaningful use. It was near the end of September when they actually hit it, but we actually took a 90-day segment that was inclusive of September 30th. So it really worked out pretty well. So we actually do some other things, like we generate reports around problemless. So this is typically the thing that our hospitals struggle with. Just in terms of time. So we actually measure problems. We report it to them daily in terms of what patients actually have problems on their problem list or not. And then subsequently we report these out weekly and then monthly, so that the hospitals themselves can continue to work with the physicians to make it happen. So in summary, the important pieces are, it's really about the people. Never forget that. You always have to manage the change as it comes around. And that engaging the administrative folks and leadership is really truly the important piece to that. You got to be honest, be transparent with the physicians, and you got to deliver a sound educational plan. You got to leverage the expertise that you have around you, both in your organization, as well as folks like Allego that can help you along, that have been down the pathway of doing this with organizations that can give you that experience that helps you get your clinicians to the level that you need them to be at. And then the important piece, of course, is that pay attention to all the training, personalization, and support that needs to happen as you go along. So at this point, stop and through. So thank you.